Hello, everyone. Before we start, I would like to ask you to put your microphone in mute for all those who are joining us. For the participants who wish to hear this presentation in Spanish, you will find an icon on your screen that says interpretation. If you click this icon, you will have the option to choose the Spanish language. Voy a repetir el mismo mensaje en español. Para quien desee escuchar la presentación en español, verán un icono en su pantalla que se llama interpretación. Es suficiente que cliquen en este icono y seleccionar español. Muchas gracias. So on behalf of the IDB and together with the bank's Office of Outreach and Partnership, who have played a critical role in all our connection globally, I would like to welcome you all to this webinar on South Korea strategies to face the COVID pandemic. My name is Ferdinando Regalia, and I'm the head of the bank's Social Protection and Health Division, and I'm honored to welcome all of you to this webinar. We have at present several hundreds of participants from all over the region connected to this webinar, and I would like to thank you all for your interest. At the IDB, we are redirecting an important part of our efforts to provide support to the countries of our region to face the enormous challenge that this pandemic means for Latin America and the Caribbean. In a situation where resources of all kinds were already very limited even before this crisis started. Part of our efforts are aimed at disseminating information on lessons learned from other countries where the virus has advanced first. Criteria is an IDB network which is dedicated to facilitating the exchange of knowledge on relevant public health policy issues, and is now focusing its effort on disseminating information on strategies to face the COVID epidemic. As part of this effort, as you can see on the screen, Criteria is systematizing information on the strategies used in LAC to tackle this crisis. It's also organizing a series of weekly webinars that will present experiences from countries such as South Korea, China, Germany, and we will add more in the coming weeks. As you can see from the table, we will have some very interesting weekly webinars over the next coming weeks and invite all of you to register for them. Our invite guest country today is South Korea, which has received a lot of attention lately for slowing down the spread of the epidemic with a combination of measures, including social distancing, mass testing, and close monitoring and tracking, among others. I want to invite all of you to learn more about this valuable lesson from Dr. Seon Kyu Lee. We welcome her and we thank her. Dr. Lee is currently the head of the Risk Assessment and International Cooperation Division of the Centers for Disease Control and Prevention in South Korea, an entity that is somewhat resembles the United States CDC or the National Institutes of Health that exist in our region. She has been at the front line of managing the epidemic in South Korea, and here you can see her impressive curricula. Before passing the word to Dr. Lee, I will invite you to ask your question throughout this webinar by sending your question via chat to everyone. Dr. Lee will answer your question at the end of the webinar in a 30-minute Q&A session, which will be moderated by my colleague, Bill Savedov. And as a matter of order, as always, please put your microphone in mute so that there is no interference in the sound, even more so given that there are several hundred people that are connected today. I just also want to let you know that the video file and the transcript, both in English and in Spanish, on this will be shortly after published on the website redcriteria.org. And I take this opportunity to invite all of you also to review other resources that we have on this website, including dozens of conferences on issue of explicit priority setting and pharmaceutical policy. Now it's time to start. I would like to thank Dr. Lee for joining us. Her time is really, really precious. I would like to express her our sincere thanks for accepting this invitation and for giving us a conference at a time when everyone's agenda seems to be completely overwhelmed and the time is a very scarce commodity. So we really appreciate your being here with us today, and thanks very much.
I'm sorry, can I interrupt just a second? Dina and Greg, can you start translating, please? We cannot hear you. Thank you.
Okay, are we okay with the translation?
Yes, please continue.
Okay, thanks very much. Then Dr. Lee, thanks very much. The floor is yours. Thanks very much.
Thank you very much. Good morning, good afternoon, and good evening, everyone. It's my great honor to share our knowledge and experience on responding to COVID-19 in Korea. Let me begin the presentation. Next slide, please. This slide shows the timeline, how the situation has gone, and how our...
Dr. Lee, I'm so sorry, just 1 second. Hugo, it seems that the translator, people still cannot hear the translation.
Yes, Greg, did you change something in your settings? I cannot hear you. Oh, Dina, can you start the interpretation? Yeah, we can hear you. Yeah. Okay, thank you. Right,
I'm so sorry, Dr. Lee, we can continue.
Okay, I will start again with my first slide. This slide shows the timeline, how the situation has gone and how our government responded to COVID-19. As you can see in the timeline here, we issued alert level 1 blue after the cluster of cases of pneumonia of unknown origin in Wuhan, China, was first reported so that we could be prepared for possible importation of COVID-19. We gradually raised our national alert level as the outbreak progresses. The alert level increased to level 2 when the first case was confirmed in Korea, and then to level 3 after more imported cases were confirmed. The secondary and tertiary infections were reported after then. Finally, we raised the level to the level 4, which is the highest level in responding to the big clusters, Shincheonji religious groups and Daenam Hospital occurred. Next slide, please. Actually, this graph shows the total number of confirmed cases and the confirmed cases in each day since the first case was confirmed on January 20th. As of March 27th, there have been 9,332 cases in total in this slide. But as of today, it's our confirmed cases the number of our confirmed cases is 9,786. The peak of the transmission so far was on February 29th with a record of 909 confirmed cases in a single day. After then, though, the newly added cases have been slowly decreased. Since March 12th, the number of newly confirmed cases have been around 100 recently. We are trying our best to maintain the number of new confirmed cases, not exceeding 100 right now, and hoping that it can decrease as many and as fast as possible. Next. The next couple of slides are the basic epidemiological information of the confirmed cases in Korea. The one on the left is the age distribution of confirmed cases. The distinctive feature is that we have the largest number of confirmed cases in the age group of 20s. It's quite unique from other countries, the aging group distribution. The reason we have more patients in age group 20 to 29 is because the big cluster Shincheonji religious group is mainly targeting young people in 20s for their missionary works. On the right-hand side, you can see the number of fatal cases and the fatality rate on each age group. The highest fatality rate is 15.2% in age group 80s and above. And the overall case fatality rate is 1.49%. Therefore, as a mitigation strategy, we established a new system to put more resources on severe cases. First, we categorized the confirmed cases into 4: mild, moderate, severe, and very severe. Each category receives a different treatment and get admitted to different facilities accordingly. Next slide. Next slide indicated distribution of the confirmed cases by region and cluster. The graph on the left shows that Daegu and Gyeongbuk provinces, where Shincheonji cluster was found, have the highest number of cases. Other regions such as Seoul, Gyeonggi, and Chungnam are also experiencing relatively small clusters, bringing the current total number of the cases to around 300 or more in the regions. Furthermore, the number of cases found in the airport screening is 104 as of 27 March, and it seems to increase relatively fast. Taking into account the outbreak situation all over the world, it is sort of expected. Therefore, we are more keen to strengthen our screening system at the point of entry and actively monitor and test all the incoming travelers. The pie chart on the right proportion of the clusters in Korea, as you may already know, Shincheonji is the biggest cluster as indicated in blue. Orange represents other clusters. This is the next slide, please. This slide summarizes the response measures taken along with the progress of outbreaks, especially after we found out local transmission, including Shincheonji cluster. Right after we recognized the case number 31, which was confirmed on February 18th, was related to Shincheonji religious group, we started to identify the test for all the members of Shincheonji Daegu group. As the cases increased and evolved to the big cluster, our government escalated the national alert level to 4, as I mentioned before, and designated Daegu and Cheongdo City as a special management region on February 9th. When we had a peak on our epic curve, we started the social distancing campaign as well. And the school opening has postponed on March 2nd until March 23rd, postponed till April 6th again, and then further postponed till April 9th. Currently, we actually announced that today. And then the schools will be open gradually, maybe on April 9th. The school will open for the third grades of junior high and high school students, and later some other the grades step by step. While responding this big cluster, we have taken various measures, including the update of case definition, the designation of national safe hospitals, establishment of living and treatment supporting centers, deployment of public health doctors, and so on. Next slide, please. Actually, this slide is about our testing capacity. It is well known that Korea has conducted extensive lab testing and found cases at the very early stage. We have extended the testing capacity step by step. In the beginning of the outbreak, only KCDC was available for lab testing. But later on, it was expanded to the research institutes of public health environment affiliated to local governments, and then further expanded to private medical laboratories and hospitals. Therefore, currently, we have a total number of 118 testing institutions available nationwide, and the capacity is average 15,000 testing per day on average, and 20,000 per day maximum. Next slide, please. These are the pictures of drive-through sample collection and screening clinics. As you might already know, these drive-through clinics have contributed as well to our testing capacity. They don't actually do lab testing. It's until the sample collection. So by like a drive-through, each car, each person can get some kind of diagnosis, and then they can go for the sample collection, and these samples will be transferred to the testing labs, and then they will test. Then you will get the testing results, whether it's positive or negative. Next slide, please. Another aspect I would like to touch is our contact tracing strategy. There are mainly 4 steps: investigation, risk assessment, contact classification, and contact management. At the investigation step, we obtain the preliminary information through interviewing the patient, primary physician, and family. And then to compensate the missing information or confirm the interview outcomes, we collect additional information at the stage of risk assessment. The information, such as medical records, mobile phone location using GPS, card transaction log, and video footage are collected and investigated in this stage. Based on this information, we classify the close and casual contacts and provide guidelines accordingly, from move restriction to symptom monitoring. Movement restriction refers to a legal public health order for quarantine and controlled travel. Symptom monitoring can be either active or passive, depending on the exposure risk. All these kinds of activities are authorized under the Act. Next slide, please. Even I will just briefly explain about the smart quarantine information system which was established after MERS outbreak in 2015. This is done actually at the airport quarantine station screening at the point of entry. Even before this COVID-19 outbreak, every inbound traveler entering Korea is required to be checked for fever and also to fill out a questionnaire about their health condition when they visited in risk areas in general. In particular, people who have traveled or lived in the areas with outbreaks of certain categories of infectious diseases with high risk, such as MERS or Ebola, are subject to quarantine investigations, including individual temperature checks and health questionnaire, as I mentioned before. In order to enhance our quarantine system after MERS outbreak in 2015, we introduced the Smart Quarantine Information System. This flow chart shows the overall workings of the Smart Quarantine Information System. The information about the inbound traveler from the Ministry of Justice, the Ministry of Foreign Affairs, airline companies, and major telecommunication companies are collected by KCDC's Quarantine Information System. Then the information gets recategorized. So we can, in advance, before the airplane just arrives at the airport, we get these the information for this kind of the quarantine subject. Then we just get ready for these people from the risk areas for more close the quarantine procedure. The information about travelers from a country or region with an infectious disease outbreak is accessible by the frontline healthcare providers during the incubation period as well. Actually, we just share this information with the healthcare insurance system as well. Since the frontline healthcare providers can check the international travel history of a suspected case at registration, treatment, or prescription stage, they are able to quickly identify and treat the suspect case in a timely manner. Based on the information collected from the inbound travelers at the entry, if a person returns to Korea after traveling to a region affected by an infectious disease, we send text messages also to that person during the incubation time about how to report if they develop symptoms of an infectious disease. Since we send text messages through local telecommunications company, they need to have a domestic cell phone number to receive these text messages, which covers most Koreans as well as most foreigners who are living in Korea. Actually, this system plays a very important role in responding to COVID-19 for early detection of imported cases. Next slide, please. Then actually, in this in the course of responding to this COVID-19, we further adopted IT technology for efficient and creative measures, such as the self check mobile app, as well as self quarantine safety and protection app. This slide shows how the self check mobile app works. All inbound travelers are required to install this app on their smartphones and submit their health condition every day on the app for 14 days. If they show symptoms of COVID-19 infection for more than 2 consecutive days, KCDC and local health authorities follow up to take the necessary measures. Next slide, please. Last strategy we emphasize is the social distancing campaign. After the peak of the transmission on February 29th, we has recommended the public to practice social distancing. Although it was a recommendation back then, now we practice enhanced social distancing. We advise the public to cancel non-essential travel, event, and social gatherings, and so stay home as much as possible. High-risk facilities such as religious facilities, indoor fitness facilities, and nightlife venues are strongly recommended to suspend operation. Venues that remain in operation must strictly comply with the infection prevention guidelines. All these recommendations are subject to administrative order. Finally, I'd like to emphasize that COVID-19 is novel virus. we still needed to learn more about its characteristics. Till now, we have known that COVID-19 is highly infectious from its early stage and spreads rapidly with cold-like symptoms. New technology such as IT is required to enhance our traditional control and response measures, as well as to develop innovative measures. Currently, the world is experiencing the pandemic that we have not ever experienced in recent years. We really needed to share information and work together to resolve all the challenges and overcome this crisis. I really hope our experience can help other countries to take effective measures against COVID-19 under their circumstances. Thank you.
Thank you, Dr. Lee. Thank you very much. That was an excellent presentation and gives us quite a lot of information about the Korean response. It's remarkable. It's you've saved many, many lives, and you've given a lot of other countries hope that we can curb this epidemic, this pandemic. My name is Bill Savadoff. I'm a principal health specialist working with Ferdinando at the IDB, and I'll be moderating the question session. We've already got some good questions, so I hope you'll be able to answer them. The first question is a fairly general one, but important one from Octavia Martinez. She asked if you had maybe 3 key suggestions for the countries in Latin America and the Caribbean for what are the first 3 things that you would recommend for them, especially given that many of the countries have limited resources.
Actually, I'm not sure whether which stage or which phase that we are facing, because each country may have different phases or stages. But the most important thing that we really consider is the preparedness for the next step. Every stage that in Korea, we've just overviewed our situation and evaluated our situation. Then we just considered all kinds of the scenarios, and then we always put the worst scenario at the first. And then we just tried to reorganize our system and our resources every stage before something just comes up. Actually, basically, we need some public health system that can respond to certain public health emergencies. You have to actually look at your public health system, and then you have to actually just prioritize which resources that you have to use and which strategy that you have to use. Actually, in Korea, we had a full capacity and the available resources about the lab testing. So our first strategy was finding out the cases as fast as possible. So early detection was really important. From our MERS our experience about the MERS outbreak in 2015, the one important case that could lead to local transmission and further progressing to the big cluster. So the early detection was very the major approach and measure that we've took. You need some kind of the resources for lab testing. That's one of the strategies that I can suggest. But if you don't have these kind of strategies, you may maybe use some kind of restrictions to the people, like strong social distancing strategies, and then maybe sometimes you have to use certain strong, the containment strategies, maybe, excuse me, and also, and then some other strategies that you can do that is that you need to maybe have some kind of priorities to find out certain population, especially for the risk groups, high risk groups. Maybe you have to put your resources into these high risk groups. For example, elderly or some people with underlying diseases, and also some vulnerable people group, because they are the groups who will develop to the very the severe cases, maybe to the death. So to protect them, and then you have to just put some more resources to make them to prevent their infection. And also you have to look at the areas that might be that have very high risk of exposure to these infection sources. So all these kind of strategies should be maybe done together or maybe in priority. So I'm not sure there wouldn't be the right answer, but we have to actually try to find the possible appropriate answer for each circumstances and then each stage.
Thank you. That's a very good reminder and a good range of responses. We also have a question from Claudia Rodriguez about how you're dealing with the strategy for people who have limited resources, especially when it comes to if it's recommended that they self-isolate and they can't get to work, or along with that, it's a similar question in terms of how you're dealing with more crowded urban areas or the disadvantaged peoples in rural areas.
Actually, we are working with the local government, the public health centers and the local governments. Actually, we take all kinds of measures, and then the local governments usually decide about their possible measures to their own the residents, because as you mentioned, the rural areas may have different measures, but usually in rural areas there are many elderly people in Korea, for example, live there, and then actually sometimes if they are sick, they cannot go to the hospital, and then for managing those people, you need to really look at the healthcare system within the area. But in the city, actually we have plenty of clinics or the hospitals, but there are more risk, higher risk in contacts, and then certain, I mean, for the transmission and infection. So in that case, maybe we will use both social distancing measures and as well, and maybe it's better to have early detection of certain the cases, and also you have to really look at these the risky groups as well. Because always the resources are limited. Actually, in the cities, we do really try to have not develop these sporadic cases into the clusters. If it goes for the clusters, sometimes you cannot just manage all these clusters, and then it's out of hand. So when we find out the case, we really go for the really active contact tracing, and then as you mentioned, the isolation or quarantine of these contacts are very, very important, not to just further progress to the big cluster. So the different measures should be taken in the different areas. Over.
Thank you. Thank you. That's very good. We've gotten quite a few questions about the testing in terms of some fairly specific about the sensitivity and specificity, the type of tests. presumably they're not all the same. You're using different ones for different purposes. Can you talk a bit about that?
Actually, in Korea, we are, for the confirmation of the cases, we only use real-time RT-PCR. That's the only method that we are confirming. Actually, some of our Korean companies are still developing the rapid testing kits, and then developing other types of testing kits. But we now consider that the accuracy is not as accurate as the RT-PCR. If we can just go for the if we have the certain capacity of performing these PCR testing, we will just stick to this PCR testing. But for the countries who do not have these PCR labs, and then these kind of equipments, or these all those things, maybe for them, some other the alternative, there might be a good alternative, these kinds of rapid kits. But still, for the as you mentioned, sensitivity or accuracy, we really need to have a very accurate testing results, because if we lose one confirmed case, one positive case, maybe it will produce more. You will transmit to more people, and then it might have some big clusters. So yeah, we just recommend to just have perform this PCR testing in Korea right now. Over.
Mm-hmm. Okay, good. And related to that, I guess several people have asked about the there are issues that come up in terms of tracking people and identifying them. I just had one question, which is when people drive in, how do you, is it all through cell phone identification you connect with people and give them their test results? But more generally, there are ethical issues that come up in terms of the government knowing where people are and having this information. So how does that play out in Korea?
Actually, there is kind of a misunderstanding. Actually, we don't take such measures to everyone. Actually, as I mentioned at in my presentation, the basic method is interview with these confirmed cases. If we get the accurate information from these the cases, we do not use additional information. We do not collect additional information. But sometimes some confirmed cases have the onset date of symptom is very far from now. Then sometimes people don't remember where they were, what they did, and who they met. In that cases, we just get some additional information for just tracing. That's just from the only use of for the epidemiological purposes, and then we really have a strict privacy measure. So we don't use, and then we don't look everybody's locations or things like that. And then we also open this information to the public through the risk communication. Only the locations that they have visited, maybe some they might cause some public health risks. If he stayed at home, and then if some person he stayed in the very isolated area, we don't open that kind of location. Only the locations that might have some the great concern on public health perspectives. So this information is really treated very carefully, and then we only collect this additional information for the only epidemiological investigation purposes. And this is actually authorized by the act, the law. So we are just doing this one, not only not in the normal circumstances. We only this one at the just national crisis circumstances. So it's kind of a limited authority that we have under the act.
Okay, thank you very much. That was very clarifying on that issue. It's one that every country is going to be handling, especially the ones that can do more in terms of the technology and the tracking. So we're getting quite a lot of questions about how you're maintaining healthy economic activity, as it were. It sounds things like construction sites or what's being done for micro, small, and medium-sized businesses to keep up incomes or to deal with layoffs or closures.
Well, actually, all these are, we really are grateful to our public as well, because their participation was also very much important to keep for us. Actually, some just enterprises or these entities are voluntarily participating in these our public health measures, and then we are very much. Sometimes we are very surprised at their active participation in this. It was done because from the beginning, our government actually had transparent communication with our public, and our Korean citizens have great understanding and trust on the government response. And strong public participation, as I mentioned, then all government approach was the key factor, using all kinds of possible measures to control such a crisis. Then our government actually recently decided to go for the subsidies for small business and also all these vulnerable groups. Currently, we just considered. Currently, we are considered this at the central level. Even the local governments, they have also their own subsidies to support all these kinds of economic loss or any kind of challenge to resolve any kind of challenges that these business and also the people who are in need. Over.
Thank you. Yeah, so the communication strategy is very critical to this in terms of getting public collaboration. We got a question from Alvaro Carreno and Katia de Pino Campos about specifically about using behavioral approaches, things that are informed when you're communicating. Are there particular ways in which you're using, our new understanding of behavioral approaches to get the desirable behaviors?
Yes, actually, we do have our government have at least 2 times briefings every day. One briefing by the Ministry of Health and Welfare, and one briefing by the KCDC mostly. And each time, actually, we give some messages and guidance to the public how they have to behavior to prevent this kind of infection. And also, as you already know, we use all kinds of media and also SNS, and then all kinds of sources of this communication. So this is this risk communication is very, very important for changing the people's behavior. We have the Division of Risk Communication at KCDC. They are very specialized and professional people who just develop all kinds of materials for making people's life change. Actually, currently we are having very strong social distancing campaign. And as I mentioned before, we are now preparing for a school opening early April. We are currently preparing for getting back to our new normal life gradually. So we say this new normal life. It's not the life, it would not be the same life as we've done before the COVID-19. If we go, even though we go back to normal life, it will be different. We have to change our social, the lifestyles. Maybe we have to still avoid big gatherings, and then we have to behave for in parallel with these infection prevention and control measures and all those things. Our government is preparing for all these guidelines and messages for how they can behave to go back to the normal, new normal life. During this social distancing campaign time, we have just we have been doing this preparation, and then we will communicate with our public more about this for next month.
Thank you. I like that phrase, new normal life. I think that's what a lot of countries are hoping to get to very quickly. It sounds like it's sort of like looking ahead to the next phase. If you can get there, that's the one we're all after. It's interesting you say that also, because it's obviously a mental state that you're asking people to sort of think about, is just to change our own mental states. And several questions have asked how you're dealing in this phase of the crisis with mental health issues, psychosocial issues, and the effects of people not being able to get to large gatherings or being isolated in their homes.
Excuse me. Actually, we are having this psychiatric consulting service by phones and from our this academic society, and also some the clinics and hospitals participation. So we are giving this kind of service to our people, as you mentioned, about to manage this crisis for mental state. So this is that's very important thing. And then sometimes you need this not only this kind of direct service, but we have to also communicate very in a very smart way. As I asked, as I mentioned, the risk communication. Risk communication also includes about the kind of a negative message sometimes, but we should also include the positive messages to make people to be more, not to be anxious about all these crises. So we really just review our messages, and then review our briefing messages also to communicate with the public in a very appropriate and effective way, to give them the strong messages not to do something, but also some very comforting messages for them to ease their anxieties and then their these fears. So this communication is very, very important, I think, in this in the middle of the this infectious disease outbreak. Over.
Thank you. And how important has it been coordination between different levels of government in terms of getting those messages across, and also providing sort of the local support networks that keep people from being actually isolated?
Actually, every day, our prime minister actually he just organized the meeting, all the whole government meeting. So they just sorry. We always just have discussions, all the ministries participated. So, excuse me. Yeah. So we are just discussing and having the same, trying to have the same messages from the government side. So also all these briefings have the one voice, and then this communication has we really try to have the one voice message. So if there are some messages for the certain the group of people, like some messages for young people, some messages for these healthcare workers, some messages for the elderly, and all these kinds of messages we actually review together, the whole government. And then also if there is some certain kinds of the challenges that each ministry has, some like for example, the Ministry of Education is preparing for the school opening next month. Then we actually have the special meeting between the ministries to have some internal consultation and discussions to develop the guidelines or certain protocols for the schools and the students and things like that. So maybe every day actually, because we have a lot of meetings for the special subjects, and then these all the meetings are actually the multi-ministerial meetings. So yeah, in this certain level 4, the crisis level, the whole government is working together. So that's why we have this kind of disaster, the risk alert level in our government. So if it goes to the highest one, it's very controlled by the prime minister, the highest level. All the ministries are just gathered and just work together. Over.
That's very impressive. And I assume this is even though many people are from different parties, but they're still coming together around the same messages. Is that so? That's something very impressive for us to all aspire to. Thank you. There's another series of questions about protective equipment, about masks, and in particular. So I guess if you could tell us a little bit both about how you're protecting healthcare workers in terms of protective equipment, other people in other areas which might be vulnerable, and then the general use of masks by the population. Is that being encouraged or not? And if so, how do you manage that?
Especially these PPEs, the personal protective equipments, we've had our KCDC actually to prepare for this kind of national crisis. We actually had stored the certain amount of the PPEs in normal in the normal days. Actually, we've already had our own storement, and then when this outbreak has started, we actually distributed these PPEs, the special PPEs, to the healthcare practitioners and healthcare workers. And when it, and then we tried to maintain this certain number of the PPEs at the government, the stock, so that healthcare workers can use these PPEs sufficiently, but we are also we have also considered the certain area, a certain period of a certain phase, maybe EURIB is kind of out of stock, and then we had some kind of priorities for distributing these PPEs to these healthcare workers who are treating the severe cases, maybe in the ICUs, and then or some the healthcare providers at the tertiary hospitals and things like that. But currently, we are now on quite under the control about that, about those the healthcare providers. If they inquire some the PPEs to the KCDC, we try to send and distribute some the stocks from us. And for the general public, actually, we just recommended the public to wear the masks when they have symptoms. That was the principle for the risk communication. But currently, because we found out that this COVID-19 shows very, very mild symptoms, and sometimes the asymptomatic the cases are just identified. So in that case, some people who are in contact with a lot of people, we just recommend those people who just give some services to many people, to the people, or they meet a lot of people. They we recommend them to wear the masks for their personal protection. So it's for the high risk groups, we just recommend to wear these masks. Actually, the masks are very, I think we just consider that it's very effective, but because of the limited the resources, we sometimes have to prioritize these resources. Currently, because we had some kind of shortage of masks for the general public, now our government is just providing this public mask, the sales. Each person can buy 2 masks a week on the certain day that they can buy. So we are in a very reasonable price. It's about like $1.50, maybe $1.50 for each mask. And then they can buy 2 pieces of mask a week. So that's our government public service to the public, and then we are actually controlling all these the distribution and sales of these masks currently in the nationwide.
Thank you very much. That's very, very useful information too about the mask. That's a big question in a lot of places, and especially in our region with the limited resources and trying to get supplies in place. The prioritization seems to be a real critical factor for that. And the collaboration of the public, again, is another issue. I'm aware that it's 11 p.m. in Korea, and we really appreciate that you took the time, and it's such a late time to join us all. I think I have another 96 questions that have come in on our list, and I'm sorry for everybody that we can't ask all those questions, but I hope you learned a lot from this. I certainly did. I really appreciate it. Our region has a very wide range of experiences right now. Brazil has the most confirmed cases at the moment. We have countries like Peru that's been under suppression measures for I think over a month now. Other countries that have very few cases but have been able to keep limited numbers of cases coming in. We don't know what's going to happen over the next months, but I can only say that Korea is a real inspiration for us. And the idea that we all have a new normal life coming after all this is also very encouraging. So with that, I'd like to thank you very much, Dr. Lee, for this conference. I'm sure that many of the strategies and lessons you presented today are going to be really welcomed by the countries in the region. And I'd like to remind the participants, the conference is going to be available online on our network, www.redcriteria.org, redcriteria.org shortly. It'll be there, including the presentation. And last but not least, we're going to hold another webinar on COVID-19 next Wednesday, April 8th at 3 p.m. Eastern Standard Time. And at that time, we'll be hearing from Professor Joshua Sharfstein from the Johns Hopkins Bloomberg School of Public Health about what works to smooth the curve of the epidemic. So I hope to see you all soon next Wednesday. Thank you, all of you, for participating today, and mostly thank you, Dr. Lee, for sharing your experience and your knowledge with us.
Thank you very much.